Hello, everyone, and welcome to Neurocracy. Today, we're joined by Dr. Anup Katyal, a critical care and sleep medicine physician who spent years studying how sleep disorders affect overall health. He's published widely on everything from pulmonary embolism to the impact of poor sleep on long-term health, and he brings a unique perspective on how sleep connects to modern medicine. Dr. Katyal, thank you so much for joining me today.
Most welcome. Thanks for having me.
Yeah. So, my first question for you is what first got you interested in sleep medicine?
So, sleep medicine is something that, when we go through medical school, at least growing up, there was no mention of sleep medicine at all, at least in the curriculum and so forth. And if you look at it, on an average, obviously it changes as one grows older, but on an average, you spend about 8 hours sleeping. That's 33.3% of your life. So, what happens in that period of your life, a third of your entire life carries a lot of significance as to how you function and how you do during the daytime. And so whether it's regards to insufficient sleep, or whether it is things that go wrong at night, whether it is sleep apnea, parasomnia, and other kinds of things, that made me think more about sleep medicine. And here we live in a world that is fast forward in the morning, stopping at Starbucks. No one has time. So
Yeah,
that made me think that sleep is very important and integral part.
right.
And that's what made me interested in this field.
Yeah. So, could you talk a little bit of maybe what you do, kind of in terms of research or care in terms of sleep? Like, what specifically kind of is your interest in it?
So sleep, again, for the most part, when we see patients in the outpatient setting, but there's also a big inpatient, role for sleep medicine. And I'll just give you one small example, something called obstructive sleep apnea.
Yeah.
Uh, you know, Only last week, American Academy of Sleep Medicine came up with some guidelines for managing sleep apnea in the inpatient setting. And just to put things in perspective, if someone has sleep apnea and gets admitted, this leads to 17% increase in length of stay and about 67% increase in costs if sleep apnea is not treated. So this is just, I'm
Wow.
talking about the inpatient world. And
Yeah.
if you look at the outpatient, entity, then definitely, this has a huge bearing. When patients come and say, go to the primary care physician and say, they don't feel rested, don't feel, you know, uh, uh, up to the mark and so forth. The first inclination is always to say, you have some mood disorder, either you have anxiety, depression, or ADHD, and no one asks a simple question that about do you snore, do you stop breathing? And if you treat your underlying sleep apnea, that has a huge bearing. So we've done a lot of studies, whether it's related to pharmacotherapy, or we're also involved in one of the longest studies called the Apple's apnea positive
Oh,
pressure
yeah.
long-term effects study.
Yeah.
And so those things, still are ongoing, and we still sleep medicine is still a very nascent branch, and a lot needs to be done and learned as far as sleep medicine is concerned.
Yeah. So going like deeper into sleep apnea specifically, I know you mentioned snoring, but is there any way for people to kind of like I guess improve awareness of this condition or maybe like warning signs that can kind of give a sign towards this?
Sure.
Yeah.
So one thing is very important, that to understand that everyone who snores does not have sleep apnea, but everyone who has sleep apnea snores. So if you look around,
Yeah.
there are far too many people who snore. That does not mean that they have sleep apnea. So if someone is snoring, the problem could lie anywhere from the tip of the nose to the back of the throat. In other words, if you have a deviated septum, an enlarged turbinate, nasal polyps, or allergies, all that can contribute to snoring. But when
Yeah.
we say someone has sleep apnea, that's a more serious condition, where what I'm talking about mainly is obstructive sleep apnea. There are different kinds of sleep apnea. One is central sleep apnea, one is obstructive sleep apnea. And
Yeah.
sometimes when you treat obstructive sleep apnea, you get to see a lot of central sleep apneas, but the focus mainly is on obstructive sleep apnea. That has significant ramifications, with regards to, if you have obstructive sleep apnea, the best way is a simple screening tool. We use in medicine, it's called stop bang, and I can go over that quickly. And
Yeah.
what that stands for is S for snoring. T, do you feel tired during the daytime? O, has anyone observed that you stop breathing? P stands for high blood pressure, and BANG stands for B is body mass index. Obviously, heavier you are, the more
Right.
likely you are to have sleep apnea. A is age. As you grow older, the incidence increases. N is neck size. So
Oh,
a female with a neck size of 15 inches and a male with a neck size of 17 inches is a risk factor for sleep apnea. And G is gender.
okay.
More common in males and females up to menopause. Beyond menopause, it is equally as common in males as in females. So you can ask a simple questionnaire. If you don't want to go to the whole length, just the stop part, if 2 out of 4 answers are yes, then you should be checked for sleep apnea.
Yeah, that's a very useful mnemonic to kind of remember that. So, um, also, I guess one of the other questions I had about sleep apnea in general, not just obstructive sleep apnea, is why is untreated sleep apnea dangerous? And why is it so important that people kind of like realize that they have it using these kind of techniques or getting a screening?
Sure. So obstructive sleep apnea, it's not causality, but its link is linked to high blood pressure,
Mm.
stroke, heart attack, high blood sugars, irregular heartbeat, and blood clots. It's linked to, poor memory, dementia, kidney disease. So you name any of these entities, and if someone comes into the hospital, I bet they have one of these 6, 7, 8 conditions I've mentioned. And there is a link between obstructive sleep apnea and these conditions. For example, we see a lot of referrals that patients who have atrial fibrillation, that's a most common arrhythmia after age 50, where
Yeah,
your heart is beating in a chaotic manner. You can undergo cardioversion, that's your shock your heart into a regular rhythm, or you can undergo ablation. But if you have obstructive sleep apnea and you don't treat that, then the likelihood of the AFib recurring is double than if you treat the obstructive sleep apnea. So it has ramifications for basically your glycemic control. There is sevenfold increased risk of stroke in
wow.
patients with untreated sleep apnea. So you can imagine, the
Right.
ramifications of untreated sleep apnea.
Yeah. So I know we've been talking kind of the importance of treatment, but what exactly is like the treatment and how has that been changing in the past couple of years or decades with technology and new devices?
Sure. So you'll be surprised to know that the first time CPAP, that's like a mask that you see people wear, which
Yeah.
stands for continuous positive airway pressure, was used in the mid 1980s. That's the
Wow.
first time.
Wow.
Before that, if someone had obstructive sleep apnea, to overcome the obstruction, which I mentioned happens like right behind your tongue area,
Yeah.
people used to undergo tracheostomies, that is, create a hole in the neck so you're
That's
bypassing the obstruction. That's what used to be the treatment. But
wow.
since then, CPAP, which stands for continuous positive airway
Yeah.
pressure, is the most effective treatment. There are other treatment options like an oral appliance if you have mild to moderate sleep apnea. It's an appliance that is custom made that fits in your lower jaw, and basically you help move the lower jaw forward.
Okay.
People, some undergo surgery, but that's not that beneficial. Some people have tried like a device that goes on your nostrils. It acts as a one-way valve. When you breathe in, air moves in. When you breathe out, prevents air from coming out, and that creates back pressure to keep the airway open. If you have mild sleep apnea, there's something called Excite OSA. It's a device that you put on your tongue, and essentially you make it vibrate for like 20 minutes during the day. It stiffens your tongue enough that it doesn't fall back. And last but not the least, something that sounds very attractive is a device called Inspire. It's like a pacemaker that goes in your chest.
Oh wow.
And one lead goes to the hypoglossal nerve and one goes to the intercostal muscles. And you turn it on at night. And what essentially it does is when you take a breath in, it pushes your tongue forward.
Uh,
Not to miss the point that 70% of patients who have sleep apnea are overweight. And there was a recent study published in New England Journal suggesting that this new drug that is out in the market called GLP-1 agonist, if people
oh
lose weight, then
yeah.
that is also very beneficial. And there is more and more study. People are looking for that magic pill that they don't have to wear
Right.
the sleep apnea. Is there a medicine that can be used to treat
Yeah.
obstructive sleep apnea? But still, we have not reached that point.
Yeah. So I know we've talked about kind of managing weight as one of the ways to kind of like curb this risk for developing obstructive sleep apnea, but are there any other kind of preventative measures that people can take or follow to reduce their
So
risk?
So weight is a big factor, and
Yeah.
amongst the weight, it's not just the overall weight, it's probably the neck circumference, the weight that you carry around your neck.
Right.
Other conditions like, if people drink alcohol,
Oh
what does
yeah.
alcohol do? It causes your muscles to relax.
Yeah.
That makes your sleep apnea worse. If
Oh
you smoke, that is can cause inflammation that then increases the tendency for the airway to collapse. If
yeah.
people take certain medications like muscle relaxants, you see a lot of people taking benzodiazepines or like baclofen. Those muscle relaxants, what they can do is, they can again relax your airway, and that can make your sleep apnea worse.
Yeah. So I know we've talking a little bit about how like treatment and new drugs have been interesting in treating sleep apnea, but how is technology, for example, like I know there's like Whoop and Apple Watches, wearable sleep trackers, and there's also at-home tests, which are probably a little more advanced than the Apple Watch. But how do these kind of like how are these changing how we detect sleep apnea in this modern world? Are they improving it or yes, yeah.
So you'll be surprised. A lot of time I see patients who come in to see me and say, their Apple Watch suggested that, they're not getting into the deeper stages of sleep. And one of the hallmarks of sleep apnea is, when
Oh,
you go to sleep, you go into non-REM, and then 90 minutes into your sleep, get into what we call as REM sleep or R sleep.
yeah,
And a lot of times what is happening is that, people have these variables and stuff. They're not absolute gold standard, but they
right.
definitely give you enough information that, and a lot of times based on that, and there's some of them come and say, look, my oxygen levels dipped at night, which is again an indication that, probably you have sleep apnea. So that is also helping uh, in making the diagnosis and causing more awareness among patients. But at the same time, sometimes people also get too much obsessed with what numbers they see. And so
Right.
what to be careful with how you interpret that.
Yeah. That's really cool that you've actually like seen that happen. I didn't expect that, but I don't wear my Apple Watch at night, but I might wear it every once in a while just to see like kind of my own sleep. But do you wear one by any chance? Or
No, I don't.
any wearables or
No.
okay, yeah. So, you've been in this field for a long time, and I wanted to ask you, especially after looking at a lot of the research projects that you've worked on, which one research project or topic fascinates you the most?
Means if you look at sleep, again, as I said, if you look at several entities,
Yeah,
there's a lot of research in the field of narcolepsy, then making the diagnosis,
yeah,
and then also the treatment options have changed. But if you look at the sleep in general, insomnia is huge, and there are a lot of medications that are there in the market. Sleep apnea would constitute a fair number because of obesity. But one thing I will also point out that up to 30% of people who have sleep apnea are normal in weight. So the only factor to take into account that you're overweight or obese would be associated with sleep apnea is not true. So a lot of times there's some craniofacial abnormalities that predisposes you to obstructive sleep apnea. Then
yeah.
there's this entity called parasomnia, and the most interesting part of that is that we see in patients who are usually males more than females is something called REM behavior disorder, which is a condition where you go into REM sleep and act out your dreams.
Oh,
So
okay.
you see it more in males than in females, as I mentioned, and people
Yeah,
have done strange things at night. So there
yeah,
is parasomnia, there is narcolepsy, there is sleep apnea.
yeah,
Again, there have been studies looking at patients with heart failure and sleep apnea. And if you treat obstructive sleep apnea, it improves your heart function. So that fascinates me a lot that, as I mentioned, stroke and sleep apnea, several fold increased risk of stroke in patients with obstructive sleep apnea.
yeah.
So,
Yeah, I
uh,
didn't even realize there was a connection there, so it's very interesting to hear that being made. And you know what's funny, actually, 2 interviews ago, I interviewed Dr. Emmanuel Bigno. I'm not sure if I'm saying his last name right, but he helped discover the cause of narcolepsy, as like the loss of the orexin neurons in the hypothalamus. So it's funny that you mentioned narcolepsy because
so it reminds me of a patient I saw sometimes back.
yeah,
To make the diagnosis of narcolepsy, as you have to have excessive sleepiness.
right,
Uh, then you have to have something called cataplexy, which
yeah,
is a condition where you sort of tend to lose control
yeah,
of
the
your
loss of the
muscles,
muscle tone. Yeah,
muscle tone with,
yeah,
emotions. People may have hypnagogic hallucinations
yeah,
that is, as they're falling asleep, they may
right.
more visual than auditory, and they may have sleep paralysis. So if you have that constellation, then it makes it easy. But how do you prove it? So you have
Right.
to do an overnight sleep study followed by naps during the daytime, and that's how you make the diagnosis of narcolepsy. But to have that study and the naps performed, you have to be off of all psychotropic medications, which is sometimes not practical.
Oh,
So what I'm trying to say is if people are on antidepressants or any
yeah.
other medication, you have to stop those medications before you can do the test because those tests, those medications can affect the REM sleep and so forth.
Right. Yeah.
So I still remember a patient who was just 19, 20 years old, where I could not get that patient off the medication. So I got a lumbar puncture. That's when you go with a needle into the spine and
Yeah.
get fluid, and we can check CSF, orexin, or hypocretin.
Ah, yeah.
And number that is mentioned is below 120, and that patient had zero.
Wow.
So that's how we made the diagnosis of narcolepsy. And
Yeah, yeah. That's a very, I didn't even know that people used lumbar puncture to diagnose narcolepsy, but
that can be.
yeah, that's really cool. And okay, so my next question is on this podcast, a lot of what I try to do is connecting research with things people can do. So I wanted to ask you, what's one small change that people can do tonight in their own lives to improve their sleep?
So I still think, as I said, insufficient sleep. And when I see someone with, say, excessive daytime tiredness or sleepiness, it depends on what age group you are seeing. But one of the most important things I see is, people are going to bed at 12, waking up at 5. So if you get 5 hours of sleep,
Yeah,
that is not sufficient. I'll
right.
also point out, like is true for a lot of things in medicine, extremes of everything is not good. So too little sleep is not good. But if someone is sleeping too much also, that's not
Yeah.
good.
Yeah.
So people ask this question, what's the right amount of sleep? So the answer is that, you see how much sleep you're getting on a weekday when you work and
Yeah.
how much sleep you're getting on a weekend when you do not work.
Yeah.
So if on a weekday you're getting 6 hours of sleep, but on a weekend when you're not working, you're getting 10 hours of sleep, then the right answer is that you need about 8 hours of sleep. So
Ah,
how much sleep an individual needs is based on that.
interesting.
What the whole purpose is, you should get enough sleep that you function well during the daytime. So
Right.
depending upon age groups, you see insufficient sleep is one of the most common things that I see. And people have to, as I mentioned, you're spending 33.3% of your
Yeah.
life.
Yeah.
You should spend adequate time sleeping. It's just like your, car battery. If your battery is not charged, your
Right.
car will not work. Similarly, if your brain is not charged in the morning, your day will not go well.
Yeah. And I think unfortunately, especially like I see it in my school and kind of like on social media too, it's almost like glorified to have like sleep deprivation. You know, it's seen as like the as some sort of like sign that you're doing like working hard. But I'm not sure if like prioritizing or like losing out on like the health benefits and the importance of sleep is kind of like hurting that as
So
well.
one of the things is, you must have heard this in the world of sleep, something called circadian rhythm.
Yeah.
You
Yeah.
There is something, when it becomes dark, your part of your body produces melatonin that
Mm.
puts you to sleep and so forth. And there are certain kinds of variations. We call it as delayed sleep phase syndrome, early sleep phase syndrome. As you go into the teen years, it's normal for you to develop what is called as the delayed sleep phase
Yeah.
syndrome.
About 2 hours. Yeah.
So what happens is for a teen brain, it's but natural for a teenager to go to bed at 11 and wake up at 8. And when you have school starting at like 7,
Mine,
that
yeah, mine
makes it.
starts at 7:30. Yeah.
So definitely there are several states that have actually passed laws that,
Yeah.
the school start time should be delayed. So
Yeah, yeah.
what is so important that your school has to start at like 8 and end at 3? Why not start at 9 and end at
Yeah,
4?
exactly.
Those
Yeah.
kinds of things, I think so can be addressed.
Yeah, it's one of the things I actually talk a lot about on this channel. I'm working with the state senator right now to try to draft legislation for Missouri to try to push them back eventually. But that's going to be a long process. But
So,
high school start times are something that I like very passionate about as a high schooler myself, right? So
sure.
yeah. And my final question for you is I always like to think about the future and what's coming next. So, what are you most excited about when you think about the future of sleep medicine and research in the next 5 to 10 years?
So again, as I said, if I see 10 patients a day in my sleep clinic, about 7 or 8 of them are related to sleep apnea. So where is the treatment? And people think of, CPAP as something that you have to carry whenever you travel. But I will also point out that, the difference that it creates in their life once they get treated for sleep apnea is night and day. They
Wow.
come back as, a new person, the REM rebound, they're starting to dream.
Yeah. Yeah.
They,
Yeah.
so that is CPAP again in the right patient population with the proper guidance. I see like 80-90% compliance. But what I hear a lot is, people don't like CPAP and so forth. So the whole thing is, there was a recent study published in one of the European journals looking at certain medications. One was an SNRI and one was like a trazodone, and it decreased the incidence of sleep apnea. And how that works, no one exactly knows. So what I'm again interested and fascinated about is, at some point, will there be a magic medication that will be used to treat obstructive sleep apnea? At this point, all we have is CPAP and all
Right.
these Inspire and all these other devices. And who knows what the next 5 to 10 years will bring.
Yeah. I'm excited to see it too. So, yeah. On that note, thank you so much for joining me today, Dr. Katyal. It was amazing talking to you, and it was very interesting to hear about the connections you've been making with sleep and other disorders, especially with sleep apnea. So, thank you.
Thank you so much.